Dr. Akhilesh Sista. He is a professor of radiology at Cornell Medical School. He went to Johns Hopkins for med school, and he did residency in UCSF, fellowship in Stanford, and he has a extreme clinical focus and research experience in VTE and DVT and pulmonary embolism. So leader in the field, and can't wait to hear more about it.
So the PE-TRACT trial, this thing has been a long time coming for a lot of us involved, including the whole IR community. And we are very excited that it's off and running and off to a brisk start. So really the purpose of this is to give you the rationale for the trial, some of the components of the trial, and what to look forward to with the results that'll be forthcoming in the next 6 years or so. So here are my disclosures. Just give you a second with that. Okay. So presumably Dr. Moriarty discussed a little bit of this with you. Really the massive and low risk categories, well, I couldn't say they're totally clear from a management standpoint. You could encapsulate them with these sort of one-liners or one-worders, in which massive PE has a very high mortality rate. So the goal is to rescue that patient from death with any means possible. Low-risk PE patients are highly likely to survive and not progress with anticoagulants alone. And the intermediate risk or submassive group, we really don't know what quite to do with them. The very, very sick submassive groups going towards massive perhaps is an easier decision in terms of escalating therapy, whereas some of the ones in the middle are unlikely to decompensate, deteriorate, or die. So really, is there a role for catheter-based therapy for that population? And lurking in there is this concern about long-term disability, pretty much in all PE patients, but certainly in the submassive group who typically have right heart strain and a large amount of clot burden. So this population is the subject of the PE-TRACT trial. Now, if we were to look at one graphic at what we've learned from catheter-directed therapy in the submassive PE population and could point to one thing which says that we should continue to do it, it's this graph or this figure. And it's really all in terms of randomized trials. So what we found with the Ultima trial, which was published in 2014, is that at 24 hours, as measured by echo, the RV to LV ratio is significantly reduced when you use catheter-directed lysis versus heparin alone. At 30 days, these two caught up with one another. RV dysfunction seemed to be more prevalent in the anticoagulant-only group at 3 months. But other than that, we don't have a lot of data to say that we should routinely be using CDL or CDT or mechanical thrombectomy, whatever techniques you want to put in there routinely for patients with intermediate risk PE. Ultima was followed by one other randomized trial that was conducted in, I believe, Turkey called the Canary trial, and 94 participants were randomized into that trial before it was stopped due to the pandemic. And it pretty much showed similar findings to the Ultima trial, which is a gross oversimplification, but overall, that was the message that was obtained from Canary. But besides Ultima and Canary, interventional trials for intermediate risk PE have not included a control group. Part of this is that the Seattle 2 study, which looked at the ECOS device and ultimately gained FDA approval for it, took on this model and was looking at the RV-LV ratio change from pre-intervention to post-intervention. And that model was adopted by the FDA for any new device entering the space. So the net result is that all of these trials seen on the left blue circle were not compared to prompt anticoagulants, close monitoring, and bad supportive care, which is kind of the standard therapy for submassive PE at this point. So if you look at all of these outcome measures, RV-LV ratio, the obstruction index, death, deterioration, long-term consequences, you really don't know if CDT is actually affecting these outcomes. So if we're talking about catheter-directed therapy being routinely used for intermediate risk PE, sort of like how Dr. Goldman talked about catheter-directed therapy being routinely used in stroke now, we have to look at why that hasn't become the case, even though it seems to be more prevalent. We're all trained in it now. A lot of our training programs are eager to do more and more of these catheter-based therapies for PE. And the reason is twofold, if you were to simplify it down to really two factors. The first is that we haven't had enough patients randomized against anticoagulants alone. So if you look at the systemic thrombolytic trials over the past 2 decades, over 1,500 patients, probably more than that, have been randomized. You look at the Ultima and Canary, and we're talking about 150 or 160 patients total. So really an order of magnitude fewer patients have been randomized in CDT trials for intermediate risk PE. That needs to be corrected. The second thing is that clinical outcomes data, i.e. the RV-LV ratio, which has become a surrogate outcome, really we need to move beyond that. I think that was a reasonable outcome when PE was an exploratory disease and trying to figure out, well, how do we know whether we should proceed past this phase 1, phase 2 sort of understanding of these devices. We need to move beyond the RV-LV ratio. So that means clinical outcomes we care about in PE, things like short-term clinical deterioration, but even including those outcomes, looking at the long term, how are people doing in the months to years following their PE? And I'll give you a little more background on that in the coming slides. So speaking of that, Susan Kahn sort of highlighted this issue in 2017 with her ELOPE trial. 86 patients, all comers with PE actually. So this was, low risk, intermediate risk, high risk, and the majority actually being low risk. What she found is with very few baseline comorbidities at 1 year, almost half of them had a reduced peak oxygen uptake, which meant that it was less than 80% of predicted. This number, I think, raised a lot of eyebrows, and certainly, the concept of deconditioning as contributing to this was raised. But this number was surprising and probably alarming. But we have seen now that we are following PE patients in clinics across the country that this might be the case, that there is a significant minority of patients that suffer from a post-PE syndrome, whatever that is. And we did a meta-analysis that kind of highlighted this issue from the published data and all, there are methodological issues from which we drew from. And what it kind of showed was that NYHA class greater than or equal to 2, so 2 through 4 are not normal, 4 being grossly abnormal, happened almost in a third of patients, and 6-minute walk distances were quite short. This 415 meters is in the 4th percentile for what should be expected for age and sex match norms. So this is where the PE-TRACT trial comes in. This is funded by the NHLBI. We're currently in the second phase of the UG3 UH3 for this. And what we're looking at is the intermediate risk PE group. And it really is the submassive group as defined by the AHA statement in 2011. Anybody with an RV-LV ratio greater than 1 with main or lumbar thrombus is eligible for the trial as long as they don't meet the exclusion criteria. And these patients can be randomized to either receive catheter-directed therapy plus anticoagulants or anticoagulants alone. Now, catheter-directed therapy in PE-TRACT, since this is not a device or industry-led trial, is whatever is a FDA-cleared catheter. So that could be mechanical thrombectomy with the FlowTriever or the Indigo device, or it could be a catheter-directed thrombolysis with either the ECOS catheter or the Bashir endovascular catheter. So really, it is attempting to be a modern, real-world practice plus anticoagulants versus anticoagulants alone. Now, the focus of PE-TRACT is the sort of medium to long term that we just discussed in the last 2 slides. So looking at the peak oxygen uptake, which was what was the outcome examined by the ELOPE trial, Susan Kahn's in 2017, at 3 months, but also looking at the NYHA class at 12 months. So there are 2 primary outcomes. Now, they're linked by something called a gatekeeping assessment, and that's a little bit complex to get into at this point, but basically what it's doing is it's linking the NYHA class, which is a subjective patient-reported measure, to an objective measure, which is the peak oxygen consumption, basically meaning that if the peak oxygen uptake is positive, meaning it's higher in the catheter-directed therapy group, then we would look at the NYHA class, because it would be nonsensical for there to be no physiologic difference and there to be a difference in the NYHA class, the patient-reported outcome. That would not have as much validity as if that was backed by a physiologic outcome. A little complex, probably beyond the scope of a lot of discussion here. But beyond this primary endpoint, you can see that we're also looking at a lot of secondary and exploratory endpoints. And this is where the trial can become very rich, looking at things like the short-term outcomes that we all care about, the 6-minute walk distance that was mentioned before, quality of life, thrombus burden before and after the procedure, and in both groups, not just in one group, so we can really assess whether RV-LV ratio and clot burden and the changes we see in the short term actually mean something. Of course, we're looking at the safety of both groups, looking at the recurrent VTE rate in both groups. And there also is a very robust health economic analysis, which will tell us about the true value of this in terms of quality and cost. So that's some of the details of PE-TRACT, but let me just zoom out a little bit and try to convey why I think PE-TRACT is so important and should be really prioritized in today's environment, especially with, you know, tens of trials going on at the same time. The first is that it's independent. So it is the only non-industry sponsored clinical trial in this space right now. Now, I am not disparaging the other industry sponsored trials. I think they're good trials. I think they will offer valuable data as they're completed. However, the medical world needs that independence for the validity of CDT to actually be believed. The optics of this are very important. If all of the trials in the space were industry sponsored, that would pose a problem for any sort of adoption if there was positivity towards CDT. Along with this independence comes protections against bias. So we really are motivated to find the correct answer for a PE patient. So we have to be very scientific, have the proper amount of equipoise when thinking about this disease, so that we really do not bias ourselves towards or against one treatment or the other. So there is true randomization against anticoagulants alone. It's a large sample size, so it'll be up to 500 patients are enrolled with interim analyses beginning at 250 patients. And it is a comprehensive clinical assessment of CDT. So we're looking at both long and short-term outcomes, which is really what we need to learn in this disease space. Take you on a little bit of an imagination tour. So, the first thing is that there's a lot of uncertainty when we approach an intermediate risk PE patient. We're saying, well, we could make you better faster. We could improve your exercise tolerance, but we don't really know that because we don't have level 1 data. We don't have randomized data to tell us that the guidelines should say this or that. But imagine at the end of this trial being able to say, you have a good chance, your demographic, of having better exercise tolerance if we go forward with this procedure or not, frankly. The second is that we can, through subgroup analyses, start to get signals about which intermediate risk PE patients would benefit or not benefit from catheter-directed therapy. Alluded to this earlier, but the RV to LV ratio and PA obstruction at 48 hours. A lot has been made about this in the single-arm IDE trials for the FDA, but we don't know how heparin does with these measures. And also, we've never had the opportunity to correlate that with these medium to long-term clinical outcomes. So whether the reduction in RV to LV ratio or PA obstruction actually matters will be assessed in the trial. So beyond the peak oxygen uptake, there are a lot of other parameters we get from a cardiopulmonary exercise test, ventilatory efficiency, stroke volume reserve. So becoming more precise about our understanding of what's happening with the post-PE patient will be possible. The value of CDT with the health economic analysis, blood biomarkers. So all of these patients are getting blood samples taken both at baseline and 3 months after. So these blood biomarkers, we're collecting quite a few of them, so they can be assayed and then compared against the results of the trial. So we'll have a better understanding of, just even the natural history of PE and the response to therapy. Which CDT technique might have the highest net benefit? Again, we're not powered to compare CDL versus mechanical thrombectomy, but there will be some preliminary data that might help us to choose when and where and how and what. Enrollment into this trial has been surprisingly good, but we don't rest on that, and we know that sparse times could be ahead. So we are definitely focusing very hard on enrollment, looking at artificial intelligence, digital presentations, ethics of randomization for an acute serious illness, really will spur novel devices and pharmaceuticals and give these direction more precise definition of the post-PE syndrome, hopefully, risk stratification that's more than which ones are sicker, and guidelines with level 1 recommendations. A lot of people are involved in this trial, over 200 physicians. These are our partners. So far, we've enrolled 61 patients, 33 sites are activated. We're aiming for about 45 to 50 sites by the summertime. And we're off and running and hope to get this trial completed and all that data obtained in an unbiased manner to really present to the world. So that's what I had to present on. I hope I've left enough time for questions, and thank you very much for your attention.
Yeah, we have time for one or two questions.
All right. I'm sure, did you collect any questions? I have a personal question that kind of might be a little tangential, so I'd save that for the end.
Yeah. The one question I see from Dr. V right now is, what about post-PE depression?
That was Joji's question.
Yes, sir.
Post-PE depression. So, I mean, I think, there's probably something ubiquitous about a life-changing illness that has a component of PTSD. You see this with acute coronary syndromes. Anytime somebody's walking along and feels like their life is normal and has an event that is associated with mortality, they're going to have a lot of psychological issues around that. And in fact, what Jeff Klein, who's a ED physician in Indiana, has, and actually he's in Detroit now. He wanted for the longest time for the primary outcome of a study like this to be recurrent VTE, because that's what actually he thought matters most to patients, because they're living with this fear of this event happening again. And that measuring that is not an easy thing to do, but I think that the quality of life surveys might give us some indications, but there's absolutely a component of post-PE depression, and that probably comes from a lack of agency for one's health following something like this, especially when one thought that was the case. But I guess that's the best I can do to answer that. Dr. V always coming with the interesting and difficult questions.
And I had a little bit of a question too, a little bit related to kind of what made you want to start this trial and what obstacles you might have faced, and kind of what's the direction that it's started with, and what is it taking? Just as someone who's interested in seeing how trials are born and kind of progress.
Yeah, I mean, it's a great question. I would love to talk about this a lot more. It was never a very clearly laid out vision for myself. It was kind of like, well, there's an opportunity, I might as well keep going with it. And I have learned a tremendous amount about medicine, about project management, about professional fulfillment, and it's been a very rewarding journey, and at times very difficult and very hard, and it's required a lot of teamwork and a lot of going back to the drawing board, and I've had incredible support, especially from Suresh Vedantam on this, who did it twice already before me. And so I think a component of mentorship there is really needed to pull off a project like this. And what I've noticed is throughout the project itself, each phase is very different from the previous. So the first phase is trying to get sites activated. The second phase is trying to get patients enrolled. The third phase is trying to make sure those patients come back and get their data for their 3-month cardiopulmonary exercise test. The fourth stage is making sure sites are reporting all the adverse events at a rate we expect them to. And then the next phase will be manuscript writing and data analysis. So even though it's one project from time 0 to year 6, there's so many embedded individual steps and mini projects really along the way that though I've been very focused on this, it's really expanded my world.
That's a great answer and very insightful. Thank you very much.